Good evening to all the attendees and all those who have joined us today. I'm Dr. Sanskriti Patel, and on behalf of Ventas Pharmaceuticals, I extend a warm welcome to this 23rd episode of Endocrine Talk Show. We all know that GLP-1 receptor agonists have emerged as a cornerstone in diabetes management, providing comprehensive benefits that extend beyond glycemic control. As we continue to seek holistic approaches to diabetes care, GLP-1 RAs stand out for their multifaceted impact. And in today's session, our esteemed panelists will delve into and discuss the transformative impact of GLP-1 receptor agonist in managing type 2 diabetes, and more so, its potential to redefine our treatment paradigms. To moderate and chair today's session, we have with us Dr. Shubhankar Chaudhary, who has been and is an integral part of this webinar series. Dr. Chaudhary has been an invaluable asset to our program and has constantly provided valuable insights and expertise, and we look forward to yet another informative and engaging discussion. So with great pleasure, I welcome Dr. Shubhankar Chaudhary. He's currently Director, Department of Diabetes and Endocrinology, Medica Super Speciality Hospital, Kolkata. So without further ado, I hand over the digital podium to Dr. Chaudhary and request him to introduce and welcome our panelists for today's session. Sir, over to you.
Thank you very much, and a warm welcome to all of you. And I know month after month you've been keying up joining this program, hopefully with benefits that accrue at the end of each program. So as usual, we have a star-studded panel, expert panel this evening. We have Professor Ganpati Bantwal, who is Professor and Head Department of Endocrinology at St. John's Medical College in Bangalore. Of course, I mean, each one of them have a whole lot of other credentials to his or her credit, but I'll keep this part short. We'll rather hear from them rather than hear about them. We have none other than Professor Padma Menon, who is a teacher of teachers, who was Head Department of Endocrinology at KEM Hospital, Mumbai, and currently still is very active at the Jupiter Hospital in Thane, Mumbai. We also have with us this evening has Dr. Rajesh Rajput joined. If he hasn't, he'll be joining any moment. So Dr. Rajesh Rajput is currently Director, Department of Endocrinology at Medanta Hospital at Gurugram. And we also have Professor Shahana Shetty, who heads the Department of Endocrinology at Kostubba Medical College at Manipal. So a warm welcome to all our panelists, all our delegates. So as we know, Endocrine Talk Show addresses one or the other important area of endocrinology, typically once in a month. And this evening, the topic under discussion is GLP-1 receptor agonist. We know there has been a sea change in the management of type 2 diabetes. We are now more organocentric rather than glucocentric. And in this sort of idea, I think newer agents like GLP-1 receptor agonists or SGLT2 inhibitors are showing great promise. So as usual, we would try and accommodate questions from our audience as many as possible. Please kindly put in your questions, and I'm sure someone, Sanskriti or someone, will put them in the chat box, and I shall address them to the different panelists. So let's start with Professor Padma Menon. Now, she, as well as me and many of the other panelists, have grown up understanding that beta cell dysfunction and insulin resistance are the primary pathogenetic mechanisms for type 2 diabetes. But then we now understand there are so many other factors and there are fanciful names to them. the ominous octet, the dirty dozen, and so on and so forth. So, madam, do you believe that uh, these are useful in as far as understanding the pathogenesis of type 2 diabetes is concerned? Professor Menon.
Okay, you can hear me, no?
Yes, yes.
Can you hear me? Yes. Okay. So it was the first time that ominous octet was described by in the Banting lecture in 2008, and that is how it started, the ominous octet. And then the dirty dozen came with vitamin D and RAS and testosterone and so many other things. But you need to have, why does diabetes have all these things? So every organ seems to be involved in some way or the other, in some part due to pathogenesis or due to the effect of diabetes itself. So what's in a name? Like Shakespeare said, that we call a rose by any other name would smell just as rose. So you call diabetes, they all come to us. All of these factors would take. Some of them help in understanding, for example, renal glycosuria helped in SGL2 development, GLP-1 development. So the drugs develop because of various organs, which we know how they play their pathogenic role in these things. So that is why we have, and I'm sure in future they will add more of these. For example, there is a genetic aspect for muscle and exercise now. So if there are genetic aspects of muscle and exercise, one of the risk factor is decrease in physical activity in diabetes. So these names may give you a various picture, but when you say diabetes mellitus or type 2 diabetes, all of them come in front of you, and various organs involvement are more and more extensively described, so that we can have some mechanism of treatment whereby finally the diabetes is addressed. Finally, to say the minimum word, once you control blood glucose, all of them seems to be doing well. That seems to be still the major effect, what we learned long back. Control the sugar, keep as normal as possible, and all these complications are going to decrease, if not disappear. And I also like to remind you that blood glucose is the tip of the iceberg. So every metabolic alteration that is taking place under that iceberg is taking you down. Can't hear you. Please unmute.
Yeah, thank you. Yeah. So
Mhm.
thank you, madam. So can we now get down to Dr. Ganpati Bantwal, because I can't see any new questions in the chat box. So do you believe that GLP-1 deficiency is important in the pathogenesis of type 2 diabetes?
Yes, sir. As you know that the incretin deficiency is one of the features of patients with diabetes. Now, how you have insulin resistance, you in fact have uh, the L cell resistance, which can happen, and that's the reason you find that they have decreased GLP-1. Now, decreased GLP-1 is mainly responsible for controlling the postprandial hyperglycemia, and the contribution of this can be to the tune of 50 to 60%. So we have learned from Louis Monier's study that when your HbA1c is more than 8.5, the contribution by fasting is 70%. But the moment the HbA1c is less than 8.5, the contribution by postprandial, and in that, the contribution by GLP is around 50 to 60%. So I think when you have a lower HbA1c, this contribution plays a big role in bringing it to near normalcy. So that's the reason I feel, yes, this deficiency of GLP plays a big role in the pathogenesis and, of course, in the management of type 2 diabetes. So in type 2 diabetes, in fact, it's come down up to 20%. Some could have a GIP resistant, but then we are talking about GLP only. So GLP, you have a deficiency also. And thus, I would say, yes, it does play a big role. That's one part. The other thing is, they have been found, at least in studies, that these help in preventing beta cell apoptosis, at least in animal models. And there has been studies where they have used exenatide, actually, in new onset diabetes to see that in type 1, I'm talking, where they've used along with other molecules to see whether this destruction can be retarded. So if you think all these things, probably yes, it does play a big role in the pathogenesis, more so in postprandial and of course in the preservation of beta cell.
Right. So, I mean, I do fully appreciate the important role that GLP-1 analogs play in today's management of type 2 diabetes. However, if we look at the initial papers that looked at physiology or pathogenesis, my understanding was that if you got the glucoses under control, the GLP-1 secretory defect or deficiency tends to get corrected, by which I would think that that is a secondary defect rather than a primary defect. So what
Yeah,
are your views, Kanpat?
no, I will say there is actually a deficiency. So there was actually a paper by Julius. I don't remember.
Whatever.
It's the epiphenomenon. He asked, is it an epiphenomenon like what you are telling? No, it's actually not. So there is a deficiency. I would say there is a deficiency, and that's the reason it's acting so well. Otherwise, just controlling the glucotoxicity, people should have been normal, and the effect of the GLP-1 should not have been there. Forget GLP-1, the DPP-4 should not have been acting because they are only increasing the the levels physiologically, so it shouldn't have happened. So
Okay.
I feel there is a deficiency.
Right. Okay.
Julius Mayer.
Okay. Okay. So we have a question from Dr. Ashok Desai. I think we will get to those issues soon. In the meanwhile, can we have, do we have Dr. Rajesh Rajput yet?
No.
If not,
I think he has
maybe-
joined, no?
has he joined? What
Yeah,
does
I
the
thought I
tech
saw
team
it.
tell us?
No, not yet, not yet.
Not yet.
Not
Okay.
yet.
Okay, fine. So nonetheless, so just as you were mentioning, Dr. Bantwal, DPP-4 inhibitors are no doubt important, still play an important role. But GLP-1 analogs have taken over center stage, mainly after the CVOTs. So why do you think this difference? Is it the pharmacological, the level of GLP-1 that's important? Dr. Bantwal? Would you
Yeah,
like to take that?
I think so. It's the pharmacological level of the GLP-1 which is important, and maybe that is responsible for the CV benefits, perhaps, because they are reducing ASCVD, atherosclerosis, in the long run. So I think the pharmacological levels are the ones which are actually producing these benefits. So I agree with that part.
Okay. And this is also part of the question that Dr. Desai had asked, which was, oh no, so we have another question. I don't know. Okay, so it's about GLP-1 receptor analogs being promoted as first-line injectable agents ahead of insulin in the recent ADA ESD guideline. So would Dr. Shahana Sethi tell us as to what is your view on it? Is that your practice in your hospital?
Of course, I mean, if you go by the guidelines, I mean, before going to my practice, I think the reason they put it as the first injectable before starting insulin is because the first reason was probably because of its potency. Because if you look at even the ADA 2024 is focusing on categorizing the different molecules in terms of potency, and then among the very high efficacious and efficacious, you have tirzepatide and GLP-1 analogs and combinations which has come. So we know that they're really highly efficacious in terms of glucose lowering, where the A1C reductions are more than 0.8 and some molecules even more than 1%. And secondly, because of this additional cardiovascular and renal benefit, as we have seen in the CVOT and in the renal outcome trials, there was a significant cardiovascular and benefit in terms of reduction in the cardiovascular mortality, reduction in the cardiovascular events like non-fatal MI, non-fatal stroke, and also reduce progression of kidney disease. That's the second advantage of using it as before the insulin. The third would be, of course, the benefit of weight reduction. And then, of course, we know the benefit of a lower risk of hypoglycemia with these molecules. So if you have a patient with type 2 diabetes who is not responding to the oral drugs, and then you're looking for further optimizations, and if the patient is accepting the therapy, then GLP-1 analogs can be considered as a first-line injectable over insulin. However, if you have a patient who's come with very severe hyperglycemia, where say A1Cs of 11 and 12, maybe then I would place the insulin before GLP-1 analogs. But if the patient is accepting the therapy, and of course now with the reduction in the price, we can consider this as first injectable prior to insulin therapy.
Okay. So Dr. Shahana Sethi correctly pointed out that GLP-1 RAs are effective in lowering A1C. So would Professor Padma Menon kindly sort of let us know, the audience know, as to what is this efficacy? I mean, how effective are these? And there are, at least at this point of time, three different GLP-1 receptor analogs available to us in our country. So are they all similar in terms of HbA1c lowering?
They are little different. Some are better than others. But generally, for a diabetes patients, you could start with any one of them, whichever we have only one or two available with us. So we would be starting with that. The main efficacy of the GLP-1 agonist is that it does reduce hemoglobin A1c. Almost highest recorded is 1.8. It has CVOT effect, which is there. One of the beneficial effects which I point out is that gastric effects. In decreasing the gastric motility, decreasing the appetite, and increase the passage time, it helps in maintaining your diet. One of my patients told me after taking GLP-1 for some time, "Doctor, if I eat only that much, anyway, my diabetes would be controlled." I said, "Fine. When your diabetes is controlled, your weight is down. You remember what you're eating now and continue eating that. We can stop your GLP-1." So there are multiple benefits of GLP in this thing. And as it is cardio safe and renal safe, definitely they are better. And I think the liraglutide was found to be little more effective in weight reduction. Ozempic or semaglutide was found to be for obesity, which they are bringing out drug. So there is a difference in obesity. Apart from that, I also want to bring out a point here. There are some genetic aspects. We had done the initial study on liraglutide. One of the patients out of the 12 lost something like 30 or 40 kg. She came and asked us, in typical Marathi, "Do I have cancer? That is why I reduced so much of weight." But there were others who hardly lost 5 or 6 kgs. And then it comes out that there are some genetic aspects. Some people respond far better in weight loss as compared to others, and some people don't do so well. So I have patients of various degrees of these kind of patients. So I think that should be. Another important point is that somewhere in 1975, I used to do the journal meeting for MD Medicine. GLP-1 came for the first time with various aspects as journal article, and I had to review. And I was wondering, where is it going? It was so difficult to understand at that time. And it had taken almost 20-25 years to come into the market from that first report on what is GLP-1 and how does it act.
Right. We have a question here from Dr. Rajkumar Gupta from Agra. Sorry. And the question was about glycemic variability. So maybe whoever would, Dr. Ganpati, like to take this about GLP-1s and glycemic variability?
Yeah, I
No,
think the glycemic variability with GLP-1 is actually very good in the sense the variability becomes lesser. And one of the main reasons being these stimulate insulin in response to a high glucose levels only. So it's a glucose dependent insulin response. And that is the reason you find that the variability actually comes down. So whenever you're using this, you find it's a very smooth control. The excursions actually come down, and this is very useful. See, one thing always they have found is when you're giving insulin infusion, the beta cell rest to the pancreas happens. When you give pulsatile infusions, the beta cell rest is still better, or maybe even the maximum rest happens. That if you apply the same here, I would say this could be one of the mechanisms by which the beta cell rest and the functioning of the beta cells will be more appropriate, I would say, can happen because of this effect. This I'm talking theoretically.
Yeah. Okay. Yeah. So, I mean, so at this point of time, can we say actually that either DPP-4 inhibitors or GLP-1 analogs, they provide long-term protection of the beta cells?
Mainly for GLP, not so much for DPP. DPP is all only animal models. Maybe yes. See, now how do we say that indirectly that we are having a beta cell protection is the durability of the medication. Suppose a patient is having diabetes and you are putting him on this, you find that the addition of the next drug is retarded. I mean, it's delayed for a long time, indirectly telling that we are dealing with a beta cell rest or the existing insulin acting better in these type of patients. So there's an indirect evidence.
Okay. So one of the major uses or sort of planks because of which GLP-1 analogs are favored over other agents, of course, is because of cardiovascular benefit. So, Dr. Bantwal, would you like to sort of point out which amongst the three GLP-1 analogs that we have would be your choice in this regard? And because many people, when they're given a choice, would say, I would like an oral agent, not an injectable, even if it's once a week. So, would you feel that oral GLP-1 also, I mean, oral semaglutide will help to reduce CV events?
Well, see, we don't the trial which was used. I mean, the semaglutide, oral semaglutide was used. Actually, did show only a neutrality. It showed in non-inferiority, not neutrality, non-inferiority. It did not show any superiority. So with oral semaglutide, but then with liraglutide, you had a superiority. There was, I think, some 16% or something like that reduction in
Yes.
CV events. And the same thing with dulaglutide also, you got a benefit. More so, these are very useful for actually reducing the CV, cerebrovascular risk. In general, many of them have been found this, when they combined oral with the injectable semaglutide, then they found there was a significance. So when they combined it overall, they did find a benefit. And if you take that, yes, then I may use it. But if you ask me my choice, probably no, I may go for liraglutide or dulaglutide.
Right. So, can I ask Dr. Shahna Shetty as to when do you use this class of drugs? And that's also something that has been put in our chat box by Dr. Ashok Desai as to when do you use it?
Yes.
The criteria to start GLP-1.
So there are several indications where we would use. Of course, first and foremost, it's a potent glucose lowering agent, so that would be one reason to use. But if you go by guidelines, and we know that it is preferred in somebody who has already an established cardiovascular disease or has multiple risk factors for CAD. Like for example, I have a patient who already had an event, has multiple cardiovascular risk, or has a strong family history of coronary events. Then probably those patients would benefit. The second category of course, it has also shown benefit in reducing the progression of the renal adverse events. So patients who in early CKDs, probably you could consider using these agents. CKD, I mean, in terms of diabetic nephropathy. And generally, I mean, when initiating, I think one of the main what you say, one of the important explanation which helps patients to accept therapy is weight reduction. So that's how we mostly encourage patients to start using this molecule. So when I'm looking at a weight reduction, of course, I would look at GLP analog therapies. Yes, and then of course, like we discussed, if the patient has already on 2 or 3 oral drugs and is not responding, and prior to switching to insulin, we can consider adding prior to adding insulin, we can consider adding GLP analogs.
And do you use this class of drugs irrespective of the A1C level? If someone has got multiple cardiovascular risk factors or has cardiovascular event in the past, but HbA1c is 6.8, would you use it?
Yes,
And we have
6.8 I
Dr.
have used. Yes.
Right. Okay. So basically only for the cardiovascular benefit you have used, not also because of the or not. I mean, Even if the glucose control is not bad, even then you would be using.
Yeah, I think mostly so far we've been using where you're looking at weight reduction and also addressing other metabolic risk factors. Even in patients I have used in patients who have pre-diabetes or say mild hyperglycemia or A1Cs of around 6.8 or 7. We have used after counseling the patients, and they are willing to take it. Of course, we have used and we have found benefit in those patients.
Right. And so we welcome Dr. Rajesh Rajput. Thank you for joining.
Thank you.
Yeah.
Sorry for joining late.
Yeah, no issues. So, Dr. Ashok Desai has been waiting for you to join to provide answers to his questions. So,
Yeah.
how much weight reduction in how much time? He wants to know.
From me,
Yeah,
for use of drug, for lifestyle measure, what is actually the...
for GLP-1.
Yeah.
Oh, okay, for GLP-1. See,
Yeah,
when we are considering GLP-1 for treatment of obesity, first of all, we have to understand GLP-1 for treatment of diabetes and for treatment of obesity. These are two different things. In our country, currently, no GLP-1 is approved for treatment of obesity. All GLP-1 which are available in our country, injectable, even oral, they are approved for treatment of type 2 diabetes. Now, when we come to obesity, first, when we talk about the drugs which are available in our country, when you use in obese type 2 diabetic individual, on an average, across various clinical trial, whether it is Pioneer Plus or whatever trials we look at, on an average, 3 to 5 kgs loss of body weight is observed. But then when we look at data with GLP-1 RA for obesity, which is altogether a different scenario, say semaglutide, which is approved for obesity at a dose of 2.4 milligram. We were part of this clinical trial development program, STEP program. Step 1 was done only in obese, overweight individual, now approved in US FDA as well as in our country for treatment of obesity. Up to 15% of loss of body weight is observed with this drug to the tune of as much as 40% of the individual. Apart from that, there is another drug which is tirzepatide. Based on the trial results, again, it has now recently been approved for treatment of obesity by US FDA. It is approved now by DCGI in our country, but still both the drugs are not available for treatment of obesity in our country. But then one catch here is, although in clinical trial program of both tirzepatide and semaglutide, tirzepatide is found to be more powerful as far as weight reduction is concerned, and as much as 50 to 60% of the patient loses more than 15%, and with tirzepatide up to 20% loss of body weight has been observed. But then we have to understand a given subset of obese individual may not respond even to these powerful weight reducing GLP-1 RA. We have an unidentified, or because of lack of availability of investigation, monogenic type of obesity, various monogenic genetic defects because of which an individual is getting obese, and these drugs may not be beneficial there. So therefore, as of now, if I summarize is the GLP-1 RA, which are now available in our country, they are not approved for use in plain overweight or obese individuals.
right. Actually, injectable semaglutide has received our CDSCO's approval.
Yes, we were part of the team.
Yeah, I know, but the company in its wisdom has not yet marketed it in that form in a country yet.
No,
So
sir,
the
it is not
approval is
wisdom
there.
of the country.
No,
Actually,
so
the problem
of the
is
company.
availability. The company is not able to produce that much amount of molecule. The demand for US and Europe is so high that they are.
Sure. And a quick one, is there a cost difference between oral and injectable GLP-1 receptor agonists?
Definitely. There is a difference in cost between the drug which are approved for obesity. And just to share with you, sir,
no. Oh, no. Probably what our audience, Dr. Ashok Desai, wants to know is between the forms of GLP-1 receptor analogs that are available to us in our country, is there a cost difference? The oral
Yeah, there
versus
is a cost
injectable.
difference. There is a cost difference. Nowadays, we have even a biosimilar
Hmm.
GLP-1 RA available in our country, liraglutide, which is
Hmm.
available almost at less than half of the cost of innovator GLP-1 RA liraglutide. So definitely, if you see biosimilar vis-a-vis innovator GLP-1 RA, there is a cost difference, and it is going to be there. So it depends on which molecule you are using.
Yeah, but in between oral semaglutide and
Okay, in between
innovator
oral and injectable semaglutide, since injectable sema is not
is not
available in the
available.
country, so there is no
Right.
comparison. If we compare the cost with injectable liraglutide and injectable dulaglutide, which is available in our country, oral sema somehow little bit costlier as compared to these two injectable one. But then at the same time, patient prefers oral one. So small increase in cost is a trade-off. Patient often wants to take only oral drug.
Right. Okay. So now we come back to Dr. Shana Shetty. So we have got an understanding as to where we should be using this class of drugs. Very powerful agents. Beyond glucose control, they have multiple positive effects. But what are the contraindications in your mind?
So when we're looking at contraindications, some of the absolute contraindications would be because of the concerns of medullary C-cell tumors in animal trials. Of course, some of the absolute contraindications would be patients who have medullary thyroid carcinoma or MEN syndrome, or are at risk, either mutation positive or a family history suggesting increased risk. However, again, if you look at data, it's mostly the rodent studies which showed this, and there are some studies which reported increased prevalence, but the CVOT trials which specifically looked at these specific adverse events have not been able to really reproduce this data. However, the concern still remains, and that would be a contraindications. Then comes the concerns of pancreatitis. Again, the recent the CVOT trials specifically looked at pancreatitis. It was not a major concern, but again, we need to avoid it in patients who had pancreatitis or during acute pancreatitis. And then, of course, we know it's not I mean, it's a contraindicator during pregnancy and lactation. So this would be absolute contraindications. The relative would be like somebody who has, who has gastroparesis or is dealing with significant GI problems, peptic ulcer disease. Then, of course, those would be kind of a relative contraindications in these patients.
What about diabetic retinopathy? Because there have been some studies to suggest that retinopathy is worsened. So what should we do? Do we need to monitor? I mean, do we need to first check the retina if it's clean and then advise a GLP-1?
Okay, so I mean, when we look at this data on the diabetic retinopathy, it's not consistent across the studies. I think in 2023 there were two data. One was they looked at the Swedish registry and they found that in patients who were on GLP analog, the risk of severe retinopathy was lower as compared to those who were not on GLP-1. However, one of the meta-analysis, which include 93 trials, when they compared to placebo and those on GLP-1 analog, they found a slightly higher risk of early stages of diabetic retinopathy. Whereas when they compare GLP-1 analog versus insulin, they found that the advanced retinopathy was lower in GLP-1 analogs. So the data is not really consistent, to say that it increases the risk of retinopathy. One argument is that because these are potent molecules, and then we know that whenever there is an intensification of intensification of therapy with sudden lowering of glucose, there could be some worsening of retinopathy. That's also a postulate. So I'm not really convinced at this point of time that it is going to increase the retinopathy. I think mainly I would be cautious to not over intensify therapy, especially in those who are having say long-standing diabetes and also have retinopathy. Of course, we would screen everybody for retinopathy as per the guidelines, and those who have stages of retinopathy, we would not try to be too intensive in control or too fast reduction. Maybe that's something we should look at.
Right. Recently, I had advised oral semaglutide for a patient of mine, and the wife rang me or sent me a mail stating that I saw that this drug has got this. There's an FDA black box warning. It could cause thyroid malignancy. So I'm not happy to start this for my husband. So I'll ask Madam. So do you at all propose or do you monitor for calcitonin in patients in whom you start GLP-1 analog?
No, I don't do calcitonin in patients because that itself will put them off permanently. But generally, if you look, I was looking at um, cancer because one of the patients was on GLP-1 got a papillary CA thyroid. So
Hmm.
that led me to look into all types of thyroid cancer. And in general, all GLP-1 analogs have increased the total number of thyroid cancers as compared to people who are not receiving GLP-1. Number two, all patients who are receiving any type of diabetes management, oral drugs also have an increased incidence of thyroid cancer as compared to people who are not receiving. There's so much of data on thyroid cancer, it's almost frightening that it can happen. So normally I ask them whether there is any history of cancer in the family. There's no family history of any type of cancer, either of the parents' side, then I am rest assured. Of course, MEN1 is asked for. And number two, even thyroid cancers, if they have, then I am a little careful in not using for them because there is data. It is not proved that it is because of GLP-1, but I think that has to be done. But not giving the drug because of a rare disease, which doesn't look fair because so many people who will benefit from GLP-1 then will not be treated just because of the fear of MTC or fear of thyroid cancer. But
Right.
normally I don't do calcitonin levels.
Okay. So I'll ask Dr. Bantwal, and then I'll once again ask all our participants to put in your questions so that we can address them to our panelists. So how do you counsel your patients? How do you prepare your patients when you want to start off on a GLP-1 receptor analog? Dr. Bantwal.
Well, so as Dr. Sahana has already told, it will be usually a person who is obese patients. So I tell them, I mean, there are educate them why, how this drug act. This is not an insulin. The first thing, if I talk about an injection, is it an insulin? So I tell them it's not an insulin. And then this is GLP-1. It will help you to eat less, produces early satiety. The first thing they ask the moment I tell is, what is the side effect? So that I tell them, so you will eat less. Anything else? Nausea, vomiting. So these things could happen. Okay. So that is number one. But then we start with a smaller dose and gradually uptitrate it. So first I educate them, why is it required? A little bit about the pathophysiology. I will take a minute on that. Secondly, I tell them we are starting with a smaller dose. The side effect has already been told, how to tackle the side effect. And then we tell them gradually escalate it. So if I start with liraglutide, I'll begin with 0.6. They say do it after 1 week. I tell no, you wait for 2-3 weeks. Once you're comfortable, make it 1.2. And if you're still comfortable, then you can go to 1.8. You don't have to do it within a month's time only. It could be 2 months also. It doesn't matter. Letting get accustomed to that. And of course, to watch for the side effects of these things. If they're on other drugs, for example, if they're on SU, etc., and if the HbA1c is reasonably good, I may even down titrate and stop it. If they're on an insulin, of course, I could reduce the dose of insulin if they're already on a uh, insulin when I start this GLP-1. See, one of the things is majority are obese, and this insulin is actually because they are eating more. And the moment they take this, the requirement falls off dramatically, and there has been many instances where they went off the insulin also. So this is how I actually counsel them about this thing.
What about counseling on cost?
I tell them, see, this is an expensive. Yes, that is the main thing. That is the main deterrent. The writing is less because of that cost. Now that you have the injectable biosimilar, I'm writing left and right. I'm writing every day 3-4 patients. Unfortunately, it's out of the market now. There is no stock with the biosimilar. So the cost is very important. When I tell it is costing 10,000, they'll ask how many months I have to take.
Yeah.
So we tell no, it's not months. You'll have
No,
to take it for a long time.
Dr. Shubhankar, what I do
Yes.
start counseling them for GLP-1. And they end up telling me, we will do very good diet and exercise program in the first 6 weeks. I'm happy with that because if I can
Yeah.
get them to do diet and exercise done well and the sugars come down, very good weight reduction may be slow, that's all.
Yeah,
So I do counsel them, and it gives me at least some benefit on weight reduction.
yeah, and saving on the cost of GLP-1. Good.
Yes. No,
So,
no, the other point is every injections, even if it is once a week.
yeah. So we have a question here from Vadodara, Dr. Dhwani Patel. Can the combination of GLP-1 RAs with other therapeutic interventions, lifestyle, and she's also included CPAP, enhance the overall treatment efficacy for type 2 diabetes patients with obstructive sleep apnea? So let's say, and does the reduction in visceral fat mass specifically contribute to the observed improvement, I suppose, in obstructive sleep apnea? So who would like to take it up? Dr.
Right.
Rajesh.
So
Yeah.
just last week only, the trial on benefit of semaglutide on obstructive sleep apnea is released. So it has shown benefit in obstructive sleep apnea, and primarily the benefit is driven by a reduction in body weight. So definitely, if patient is obese, having OSA, and if you are using in such type 2 diabetic GLP-1 RA, now you have trial evidence also. Last week only, this trial has been released, so it is found to be beneficial.
Right. So though this may not yet be now a sort of an approved treatment for obstructive sleep apnea,
No,
but
it is not an
definitely,
approved
yeah,
treatment,
yeah,
but they have done a
yeah,
trial. Uh,
yes. So it
It's
gives
an
you an
approved
additional
treatment for
advantage.
obesity, no? It's an
Yeah,
approved treatment for obesity, so it's
yeah,
okay.
yeah. And so it gives you additional benefit. So
Benefit.
we
One
have a
more way of
question.
convincing the cost. One more way of convincing for the cost of it's much
Yes.
cheaper as
No,
compared to the
the
bypass.
problem with OSA is most of the time our critical care or pulmonologist colleagues are asking to use CPAP. Now, CPAP, most of the people find it so difficult to use at night, putting a mask and then sleeping. Majority of patients ultimately stop it. And CPAP is also not very cheap modality to be used by our such type of OSA patients. So when we see the cost in such type of type 2 diabetic patient, where insulin will come down, glucose will be controlled, there will be benefit on OSA, CPAP cost will be reduced. So ultimately, it is a trade-off. Probably such type of people will like to take these medications.
Right. So we have a question which actually I skipped earlier because I didn't understand exactly. I hope some of the panelists can understand and give a proper answer. Dr. Rajkumar Gupta from Agra, hormonal variations and its implications in elderly women's metabolic health. Would anyone like to take that and answer?
What does that mean? Hormonal?
Oh, I didn't answer.
Is it
Is
obesity?
are they talking about
Yeah.
perimenopause and increase in visceral obesity? I'm not sure. Is that one?
No, I don't
I
think so.
maybe
Hormonal imbalances.
It's a
yeah,
vague, non-specific question. I
yeah.
think let him make it more
Yeah,
specific.
yeah. Please put in your questions once again. Yeah. Okay. So in the meanwhile, Dr. Rajput, so do you have preference of one agent over the other? Of course, in terms of cost, Dr. Ganpati has said now that we have so-called generic or
Right.
branded generic, maybe cost is one factor. Otherwise, do you have any
No, it
preferences?
it all depends on what type of data has been generated with particular type of GLP-1 RA. Say, for example, when we talk of liraglutide and we talk of people who are having type 2 diabetes and cardiovascular disease, it is probably the only GLP-1 RA which has shown reduction in CV death. Now, reduction in CV death is not observed with other injectable GLP-1 RA, that is dulaglutide, available to us. When it comes to oral semaglutide, there are no CV outcome superiority trial available to us. So suppose patient is having type 2 diabetes, cardiovascular disease, or at very high risk of cardiovascular disease, then probably it makes a case that I will prefer liraglutide. Now, suppose weight reduction is also a topmost priority. Now, as compared to liraglutide in clinical trial development program, at when liraglutide is used at a dose of 1.8 milligram per day, as compared to that, oral semaglutide 14 milligram shows superior weight reduction. So therefore, when it comes to reduction in body weight, then probably semaglutide as a molecule is much more potent GLP-1 RA. We are talking of available in our country. So I will prefer gradually up titrating and using oral semaglutide in such type of patients. Now again, when we offer GLP-1 RA to the patient, we offer them, we have both injectable and oral. Now, if patient does not want to trick even for once or even for once a week, then obviously we have to use oral GLP-1 RA. Then
Right.
comes kidney benefits. Again, with kidney benefits, some evidence is available with injectable one. With oral GLP-1 RA, we are waiting for those such type of evidences to come. So all these small differences make us choose between different types of GLP-1 RA. Now, if patient is only having type 2 diabetes, newly diagnosed, and only risk factor, largest such cohort is studied with dulaglutide only, where more than 50% of the patient enrolled were only primary high-risk patients, where they have shown 3-point MACE benefits. So these are small differences based on which we can choose a GLP-1 RA out of the 3 available to us in our country as of now.
Right. And of course, then of course we have to leave it to the patient's choice also.
Absolutely.
Right. And we all understand that one of the major bottlenecks in the use of this class of drugs is GI side effects. So how would Shahana madam manage those GI side effects?
So, yeah, I think Ganapati sir has kind of already talking about this aspect. So, of course, we know that GI adverse effect and predominantly nausea is reported is around 25% and diarrhea and vomiting in around 10%. But again, if you see the symptoms and I'm not going into detail of pathology, but if you see the symptoms occur even in the fasting state, so we now know that it's not just the reduction in gastric emptying. It's not mainly because of the gastric emptying. It is because of the effect of the GLP on the CNS GLP receptors present in the brainstem or the post arena. So then that means that you can induce tolerance to this. So first and foremost, it's important that we educate the patients that when you're going to start these medications, you might experience some nausea and some nausea, vomiting, or GI disturbance. But then if you continue to use it, you might develop tolerance to it. Once you may prepare for them for that, generally the acceptance is better. And the second important rule is, so we say 3 is educate, escalate, and then of course effective treatment. So the first, of course, is the education. Second is escalation, where you start with the low dose and then gradually increase the build up on the dose so that they accept the therapy better. But again, any point of time, again, when we are increasing the dose, again, you explain the same thing, that if you develop a adverse GI effect and you're not able to tolerate, then we can step down on the doses. And then again, we also need to understand that we have to choose the patient wisely of where we are going to use. Somebody who's come with severe hyperglycemia, has symptoms of gastroparesis, or has severe GI symptoms or peptic ulcer disease, maybe we should avoid in those patients. So by educating and then escalating the doses, probably we could be able to address in majority of patients the GI concerns of this molecule.
But then,
What about
Shahana, sir, as you
yeah,
have rightly pointed out, actually it is through central action. Probably the drug is acting on nucleus of Tractus solitarius. So there are some studies of use of central antiemetic agents. If they are to be used, then probably initially for some days, patient might tolerate these drugs better. So what's your
Yeah.
take on that use of central anti-emetic agents?
Yes, I think the
So-
third P was of the effective management, so I missed it. So yeah. So I also giving effective therapies using central antiemetics. Sometimes just PPIs also help. Of course, I think Shubhankar sir wanted to add to that.
no, I was just trying to point out that what about the common agents, the PPIs or the domperitones? Do you ever use them? Do you advise them to deal with the side effects?
Yes, I mean, I have used in patients, and then some of the patients it does give relief. But sometimes if it is because if the symptoms are after escalating a dose, then I think coming back to the
Right.
old dose helps. And then we have seen
Absolutely.
benefits even at the lower doses. With liraglutide, I feel, I mean, what my experience has is 0.6 and 0.2 is okay, but when we go to 1.8, 1.2 is okay, but when we go to 1.8, the GI symptoms becomes very difficult. So then I step down and keep them at 1.2, or some patients even at 1.6, and we still continue to have the benefits. So I think in
Right.
that way we should address.
Yeah, right. So while the GLP-1s are, I think, have a better name in the field of cardiovascular disease protection, maybe on the kidney front so far, the data was not so impressive, the way that SGLT2 inhibitors have established themselves. But can we have Professor Menon's opinion as to whether they are also
Those,
can be used as important nephroprotective agents?
the flow study came up, no? That showed very good result. There were about 3,500 participants, more than, and 1,700 were put on semaglutide and the others on placebo. And they found that there is a nearly 24% reduction in the semaglutide primary outcome in the renal manifestations, and also about 18, that was in CVOT, and about 18% in renal endpoints which they had described. And they had taken patients who already had stage 2 or above nephropathy. So that was a very good study which showed that. And it also, the important point is that all-cause mortality was also reduced by about 20%. So this study showed that this can be used, and this is one study, flow study, which had to be terminated in between because the benefit from the study was far more, and hence it was considered um, the study was considered to be stopped because everybody should have
Yeah,
been given these drugs. Placebo was not acceptable then.
right.
So
So,
that
so
study
even
did show that renal benefits, cardiovascular benefits, and there are other benefits which are described is that it's supposed to reduce the cognitive decline in
mm,
elderly patients. There are some reports on that. And one of the complications which they didn't mention is that Ozempic phase or something which I came across. The fat in the entire phase being drawn out and fixed in something which they described as Ozempic. We have never seen because we don't use it in those doses here.
right. So since you raised the issue of cognitive impairment,
Yeah.
so there have been reports maybe a few months back about at first psychological effects of the use of GLP-1 analogs, namely depression, suicide. So
Yes.
where do you think they stand actually? I mean, there are different things, of course, improving cognitive function and causing depression as different things. But do you think that they are safe agents to be used, especially in
Um,
relation to mental health?
they generally has not been given so much of importance, though there are some reports of these things. But generally, it's not believed to be entirely because of the drug. It could be other effects also which could be present. But if anybody could add to this, I would welcome that.
Dr. Shivankar, actually, currently now the trials are on in Alzheimer's patient with GLP-1R,
Yes.
and it is found to be beneficial in patients of Alzheimer's disease. But you are very correct. Very
In
recently,
reducing the cognitive defect. Yeah.
US FDA has given warning for suicidal ideation and depression. So basically, when we are talking of mental health, probably then we have to differentiate between dementia, age-related decline, problems in memory, and depression and suicidal ideation. So if such type of patient, suicidal ideation, depression, we tend to avoid current based on warning use of GLP-1RA. But we have to wait the result of Alzheimer's trial, which is currently ongoing. And if it is found to be useful, probably we are going to use in such type of patients for
Right.
Alzheimer's.
Yeah, I
And,
mean,
and yes,
there was a
continue.
recent trial in Parkinson's disease. This is neurodegenerative study, which came in the New England Journal, I think, last month, where
Yes.
lixisenatide actually helped. But then what happened was in the placebo arm, there was a worsening of the symptoms, whereas here there was no worsening and slight improvement, you can say. So there was an editorial there. So what they say is if you take that movement score disorders, their scoring, that actually didn't improve. So they tell it is just maybe some effect is there, but then we require more on this to tell it. And rightly, as Dr. Rajput told, there is a lean trial where liraglutide is being used. We have to wait for that.
Right. And there have been also some studies, I mean, So observations which suggest that maybe uh, patients' dependence on smoking, that has also become
Yes.
less with the use of
Yes,
this class
yes,
of
Yes,
with
drugs.
use,
yes,
that's
yes.
right.
Right. So, Ganpati, so do you use with the products that are available in our country off-label use of GLP-1 receptor analogs for obesity without diabetes?
Yes. I have been using, but
Okay.
I tell them it's off label. See, I
Right.
tell them like this, see now
Yeah.
you have liraglutide 1.8 for diabetes, but the same is marketed as Saxenda 3 milligram for obesity. I told 3 milligram is used, here we are using 1.8, but you can take it. So I do that. PCOS, some girls are very obese. I have actually have used them, and when they are taking them, they are all fine. The moment they stop them, once again they'll go back to square one. So I have actually used it in many of them. And maybe somebody who wants to undergo a knee replacement surgery who's obese, I'll put them on that. Of course, a word of caution, though literature doesn't say, I'm a little bit skeptical if they have a gallstone disease. That's another thing. If you find that, I will not use that. I tell them you remove that and then we'll use, because it can produce gallstone pancreatitis, and there has been reports with at least liraglutide, the gallbladder disease is actually increased. So that's the reason I'm a little bit skeptical in those type of patients. Otherwise, yes, I do use in these.
But
How?
then I want to add here what Ganpati is saying. Actually, I partially disagree, Ganpati. Recently at Medanta, one patient from Kashmir prescribed by some of our colleagues oral semaglutide, obesity, PCOS. She has filed a complaint. The doctor has prescribed me a drug which has not been approved for this indication. So
No,
see,
actually,
patient now has access. No, no, no.
No, I
This is
have
very important
no. I
because
have
because
another
so many
question.
people are listening.
Yeah. Yeah.
If
Supposing
we are if
one of
we
them
are
Yeah.
develop
going to
Yeah. Yeah.
use
pancreatitis.
just
Yes.
a
Yes.
minute, if
Rajesh.
we
Yeah.
are going to use any of the drug, not GLP-1RA, any drug which is not approved by DCGI, then probably we should write very clearly on our prescription that this has been explained to the patient, and after obtaining consent we are writing for this, because tomorrow if something goes wrong which may not be related to the drug, the doctor is going to be blamed. So this is
Oh
a
no,
now
agree.
that
Yeah.
cannot be done. That
Yeah.
cannot
Yeah.
be done. The ethics. I'm in the ethics committee, so I come to know these rules. You have to take an ethical permission from your hospital. You are using the drug for another use. Or even metformin or pioglitazone, if you want to use for something else, which is fairly no adverse events. You have to have an ethical permission, inform people, and say that it is experiment. If it doesn't improve, I will stop the drug. No, you cannot use it. And one of them, heaven forbid, somebody develops pancreatitis and you had it, you will be paying billions of rupees to
so we
them.
have to be very cautious
It's better not to use. Yes, unless it is approved.
Yeah. I mean, that's a difficult area. I mean, you and I possibly would believe that it's likely to do the patient good, but we have to protect ourselves as well. And
That's
maybe,
right.
Yes, yes.
yeah, yeah, right. So, weight loss, we know what we want is loss of fat. But even if you are doing lifestyle changes, I mean, just diet and exercise, even then, there is some loss of the lean body mass, there is some loss of muscle mass as well.
Yes.
So, what do you think, Dr. Rajesh Rajput, this issue with muscle loss, because sarcopenia is also an issue, a problem, especially in our country. So, with the use of GLP-1, do they only cause fat loss, or do they also cause muscle loss? Do
Right.
they cause bone
So
loss?
first of all, we have to understand that whatever form of weight loss therapy we take, whether it is lifestyle intervention, bariatric surgery, or drugs with weight loss, there is also loss of muscle mass. It is not possible that an individual will only loses fat and there will be no loss of muscle mass. Now, with the use of GLP-1RA also, when there is loss of body weight, some degree of muscle mass is lost. But then the studies have shown that preferentially the loss of body weight is because of loss of fat, and even among fat, it is loss of preferentially visceral adipose tissue as compared to subcutaneous adipose tissue. But then how to prevent this loss of muscle mass? Therefore, now currently it is recommended that if patient is for any anti-obesity therapy, lifestyle, drugs, whatever bariatric surgery, patient should start consuming some extra amount of proteins, some resistance exercises, which can improve or which can maintain the current muscle mass. So therefore, it's a real issue, and we have to educate our patients accordingly to prevent further loss of muscle mass. Sarcopenia otherwise is quite common even without use of this drug in our population.
Right. So we have Dr. Padma Menon, maybe we have a few more minutes before we wind up. So what is the evidence for this class of drugs in treating NASH, or now we call it MASH or MASLD? Professor Menon?
Yeah, along with weight loss, major treatment for MASH also has been reduction in body fat, and hence these drugs will help. And currently, today, the only approved, I don't know whether it is approved for MASH, but it can be given if they have diabetes without any fear that that would also take care of MASH. But there is a newer drug on the horizon which is called resmetirom.
Yeah.
Resmetirom, but it is unfortunately studied only in phase 3 trials have been done, but only in white population, so it will not be available for us till studies are done on our population also. So there are many trials done on this GLP-1, and that is a drug which can be used for weight loss also and for
In
MASH.
STEP program, actually, what Madam is telling is in STEP program, in overweight and obese, in sub-study of STEP program, those who are having MAFLD or NASH, it has found to be beneficial in reducing the fat content of the liver. So therefore, correctly, the drugs are found to be useful. Now, dedicated studies, which is ESSENCE study, Medanta is a part of that study. ESSENCE study is currently ongoing, where liver biopsy proven fibrosis patients are given semaglutide, and the endpoint is again reduction in fibrosis by at least 1 grade with use of these drugs. This is a long study going to be completed by around 2026 or 27.
You're talking about resmetirom. You're talking about
No,
no,
it is
GLP-1.
GLP-1.
GLP-1 ESSENCE study.
Okay.
Resmetirom is now approved by US FDA for
Yes.
first drug to get approval. But as you have said correctly, we do not know when it is going to come to our country.
Yes.
Right. So quickly, let's try and cover CV protection in obesity without diabetes. What's the role of this class of drugs, Dr. Shana Shetty? Could they be the new statin?
No, I think I can probably quote this study, that is a SELECT study, which is published in NEGM, where they have looked at this molecule in patients 45 years and above with established cardiovascular disease who are obese but who do not have diabetes. And when they compared with the placebo, they found a 20% reduction in the cardiovascular composite outcomes, which included cardiac mortality, non-fatal MI, and non-fatal stroke. So this data looks promising. But again, it's a select populations. When I looked at the mean age, it was 60 years, and these were patients who had established ASCVD. So in this category, this molecule looks promising. However, I think we need more data in this direction.
Right. Finally, can we have Dr. Ganpati maybe providing his ideas whether we should be using more of GLP-1s and SGLT2 inhibitors together to give even more benefits? Should that be the order of the day?
Yeah, I think that will probably be the order of the day. And now if you see the ADA guidelines also, in patients with diabetes, with ASCVD, the first choice they are telling is use GLP. And suppose you are used that, and in spite of that, the HbA1c is still high, then probably we can use an SGLT2 inhibitors also. So without any doubt, it has been proven that now, and the added advantage of weight reduction also with these agents, and a further benefit could be also, that the heart failure risk actually comes down, especially in patients with the heart failure with reduced ejection fraction, SGLT2 scoring over the GLP-1 receptor agonist. I think that could probably be the order of the day. We are actually using in our clinical practice a lot of these molecules now that with the biosimilars being available. So yes, I think that's going to be the future, I think.
Right. So I think we had an excellent last hour learning a lot from our panelists about this new class of agents, which are getting more and more importance in the management of type 2 diabetes, and possibly now may go even beyond type 2 diabetes, or at least type 2 diabetes with other comorbidities, including atherosclerotic cardiovascular disease, kidney disease, and maybe even MASLD or MASH, all of these, and now maybe exciting new possibilities in the realm of Alzheimer's disease. So there is so many areas apart from, of course, also in addition to treatment of obesity. So I think we need to learn about this new class of drugs, know to use them at the right time, and also know how to initiate them, as all the panelists have stressed that we should be starting at a small dose. And if you gradually build up the dose, most of the time you don't have major GI hindrances. But if you do go back to the lower tolerated dose and then try to build up again, and they are effective anti-hyperglycemic agents as well. And so I think we are having promising times now, new agents and new vistas opening up for the management of type 2 diabetes. So I would like to thank all the panelists this evening, Professor Padma Menon, Professor Ganpati Bantwal, Professor Rajesh Rajput, Professor Shahana Sethi, for the very valuable inputs, and also, of course, for all our participants who have put in their interesting questions in the chat boxes that we hope have been answered satisfactorily. And now it's back to the organizers. And thanks to Intas team actually for making this happen month after month.
Thank you, sir. Good
Thank
night.
you so much, sir. Thank you so much. Thank you once again for everyone for their sincere participation. Thank you.
Thank you. Bye-bye.
Thank you, sir. Thank you, everyone.
Good night.
Yeah, bye.